Hi, my name is Cathie Biga, President of the American College of Cardiology. Thanks so much for tuning in for our latest Heart Talk with Cathie. Today we're going to be discussing the power of clinical guidance and where our guidelines come from and what we do with them once our physician colleagues have completed them. Over its 75-year history, the college has led the way in the development of evidence-based clinical guidance, ranging from guidelines to appropriate use criteria, all of which are widely cited and relied upon by CV clinicians around the world to optimize patient care and outcomes. For this guidance to continue to be of optimal value to clinicians, we must ensure that it evolves in a manner that leverages new technology and recognizes the increasing pace of research. One of the major initiatives under our new 24 to 28 strategic plan involves enabling guidance at the point of care, providing relevant, concise recommendations that can be implemented in real time and also integrated in the clinical workflow of our very busy physicians, our APPs, and our CV care team, all across a wide range of clinical settings, from our academic settings to our employed settings to our independent practices. I'm so excited to be joining you today to talk about this because honestly, it's not something that has been in my toolkit. Dr. Joshua Beckman and Dr. Ana Barac have taught me so much about guidelines, and Jae, with her incredible CV team expertise, are with me today to share their thoughts and perspectives on several of these efforts to date and what the college has been doing to modernize our guidelines and to ensure that we get them out in the field in a timely manner where you can use them every single day. We'll also discuss tips and best practices to help us move as a cohesive CV team from theory to practice and provide patients with the very best possible care based on the latest science, truly trying to reduce that global burden of heart disease. It's such a critical topic, so thank you all for joining us today. We're not live for the first time, so I don't like that so much, but I see all my wonderful friends out on Zoom. So Ana, Joshua, Jae, thank you so much for joining me today. And I really want this to be a conversation. I want it to be something that is meaningful to not only our physicians, but our entire CV care team. One of my favorite talks that I do is how to implement subspecialty clinics once guidelines are written, because the guidelines, if they just sit on the shelf or they're embedded in our EMRs, really don't get us where we want to go. So on a day-to-day basis, how do we ensure that our patients really are on guideline-directed medical therapy and optimize to it? I don't know, Joshua, is that an easy thing to do? Is it really easy, Josh, to get patients onto guideline-directed medical therapy? What do you think? You've been writing these for a long time.
So the easy answer is yes, it's very simple if the doctors and other clinicians would just do it. But unfortunately, I think our ability to translate what comes out in the medical literature and the FDA and other clinical experience takes a while to get into the clinic. And I would say the guidelines are helpful in that area, but they're certainly not the mode by which everybody changes their practice. And we're trying very hard to make it clear some of the real practice-changing opportunities that come out with every new guideline, with our top take-homes from each of the documents.
And Josh, maybe you should introduce yourself for our audience. For those few that may not know you, why don't you tell us a little bit about what you do in your day job and how did you ever get into guidelines with the college? I think that would be fascinating.
So my name is Josh Beckman. I'm the chief of the Division of Vascular Medicine at UT Southwestern Medical Center, and I spend a lot of my time doing clinical care, research, and teaching. All three things that are necessary to make sure that we move the field forward and bring other people along so they can do what they want to. I got involved in guidelines about 10 years ago because I was really annoyed that I thought some things were not being managed well, and I wanted to participate in the guideline process. I will say that I was an angry young man then, and now I'm more seasoned, and I've participated at all the different levels of guidelines, from writing committee to joint committee to chair-elect and now chair, and it's been an incredible privilege and honor to be able to help move the guidelines forward, and I hope improve the practice of medicine and improve the care of our patients. It's been a decade with Josh, which I think is enough for anybody.
So that decade with Josh started maybe when you were a younger man. What advice would you have for our early career physicians that might be out there saying, I really want to help write guidelines. I feel I have something to give. What would you say to them?
I think, first of all, I am grateful for everybody's interest in this process. I think we've had for far too long a relative black box. And one of the things I've been working on for the last several years is to open that up and make it clearer to everybody, how the kitchen works and how we bake our goods. So we've created a bunch of different opportunities for people to participate. And I would like people to participate in different aspects of guidelines creation over time. One of the more recent things we've started is a surveillance committee, which will be primarily early career members of the college, working with the chair of the next upcoming guideline, and we will give them a series of journals that they can look through, surveil for all the important literature from the publication of the last guideline to when we're going to kick off the next guideline, and their ability to go through the entire literature set, put it in perspective, put it in our evidence tables, link it to specific sections in the guidelines will dramatically increase our speed, help them understand how we obtain information about new recommendations, and put them in the center of everything that's important to get a guideline started. At the next level, we'll have a review committee, which will work in parallel with the writing committee, so that we can do our reviews far more expeditiously at the same time and reduce the time afterwards for approval. Then after that, you can participate on a writing committee and then in leadership positions of either the review committee or the writing committee. And I like to think of it as an escalator. Those of us that have been involved in the process for a long time, it's our responsibility to make sure that other people know how to get on the escalator and they can move up as long as they do their work and they're interested, so that we can make sure we always have a large number of people who are involved, participating, and we can tell everybody that this is not a secret sauce. This is a process that everybody should understand. It's pretty clear, it's reliable, it's predictable. And my goal has been basically to make it as predictable as possible, so it's not a mystery and there's no arguments about what to be expected based on the data that's available.
Excellent. And Jae is our queen of the APP world. So you have been so awesome in implementing these guidelines. Tell us, a little bit about yourself and tell me how you see the CV team really helping with guideline-directed medical therapy implementation in our clinics or in our hospitals.
Absolutely, Cathie. Thank you for I feel like I've been raised up. That's pretty exciting.
The queendom.
Yes, I love it. I love it. So the guidelines are an amazing way for us to get our hands around what kind of care we should be delivering to our patients and standardizing the care we should be delivering to our patients. But I think that you said it in the conversation we were having prior to this meeting, there were multiple guidelines coming out every year. And when you look at each guideline, they're 200 plus pages long. It represents, to Josh's point, just a tremendous amount of work that goes into these. But implementing a 200-page guideline in the middle of a busy clinic or in the middle of your rounds in the hospital can be tricky. So I come from the heart failure world. I was a heart failure nurse practitioner. I ran an outpatient disease management clinic for 10 years. Now I'm in palliative care at Johns Hopkins. Again, still very much in the heart failure world. But I work with learners a lot. And I think one of the things that ACC has worked really, really hard to do is to make these guidelines accessible at the point of care, which is so exciting. I will send learners frequently to the ACC Clinical Guideline app. That's something you can have there in your hand. And what's nice about it is, first of all the information is there. You can link through to the entire guidelines if you need to, but there are lots of summaries. And you'll find when you're early in your practice, say if you're a new APP or a resident or fellow who's working with patients who have heart failure, which is my milieu, that you're going back to dosing at first. Like, so which medicine do I start first, and what's the dose? So you bookmark it, you make it pertinent to your practice, and then as you become further advanced in your practice and you learn more and you have learners, there are slide sets and things that you can access as well, and lots of educational content. I mean, it's just there is something for everybody at every level caring for patients. We just have to know how to access it. And like I said, one of the easiest places at the point of care is that ACC clinical guideline app.
And so sort of the same question to Josh. If you have a pharmacist, a dietitian, an advanced practice nurse, as I see the guidelines as they have evolved and matured, under Josh's incredible direction and leadership, what would your advice be? How do people get involved so that they can be active in this? Because we really do need the whole team. What would be your recommendation to Susie, APP, or Bob, our clinical pharmacist, who everybody in his clinic knows he's phenomenal, but how can he really get involved at a local or a national level? Any thoughts on that?
Oh yes, for sure. So there have been a broad range of members of the medical team who've been involved in the guidelines writing committees, and also now in the review committees. We've been welcoming expertise from APPs and pharmacists and PAs and a variety of members of the medical team, because there is no monopoly on the kinds of information that are necessary to make a guideline work. Some of the best programs for control of blood pressure and lipids are pharmacist run. So they have the most experience in making sure that we tell people how to do this correctly. So we've actually been very interested, and we have made sure to include members of the team routinely. Now, to get involved, the easiest way is to become a member of the ACC. Go to the ACC membership page, and then go to the membership engagement section, and there you can volunteer. Now, that doesn't mean you're going to get it, because it's a bit of a popular thing to want to do, but I also would say keep trying, because people who are really devoted to this kind of work will find other ways to participate, and then will be able to participate. And so I would just say, find your way online, talk to the member, whoever runs your section you're interested in being involved, make connections, network, do all the things you routinely do. And then you can send Dr. Otto, who takes over for me in January, an email if none of those things seem to work.
And Ana, in case you thought I forgot about you, we go way back to my first introduction to cardio-oncology. So it's so much fun to watch you now leading our critically important Science and Quality Committee. Tell us a little bit about you and what you hope to achieve during your time as Chair of Science and Quality, and how it all intersects with what we've been talking about so far this morning. And thanks for joining us.
Cathie, I could not be more grateful to join you and this fantastic discussion that you're having. It resonates with everything I always wanted to do in the ACC. And so I'm Ana Barac. I'm a cardiologist with Innova Shar Heart and Vascular and Innova Shar Cancer. Have a dual appointment with the Innova Healthcare System, working under cardiology and oncology division to improve cardiovascular health of oncology patients. And I'm really grateful for the opportunities in the ACC that really started now 15 years ago. And I started in the ACC, even as a fellow in training, a lot of things that Josh said, it's sort of like you have to want to do it. And then the only risk is watch what you wish for, because it might actually happen. So I joined the SQC committee now 5 years ago. And this year in April, I started as a chair. And it really gave me phenomenal opportunity to look at the very wide charge and task that college has given to Science and Quality Committee to be the vehicle of accomplishing college's strategic goal, which is the transformation of cardiovascular care. And then that's where, so SQC's role is to understand what's happening in the guideline space, to assure implementation and understand the needs that live not only that will be met by the guideline. So, and what about the questions that cannot be answered by the guideline? And there are many of those. And I think there is a growing, as we really, I think we're facing unprecedented growth of knowledge and even bigger challenges. So what do you do in the patient care? So over time, the college and the board has really tasked us of creating the tools to enable all the members of cardiovascular teams to better answer patients' needs. So if we think of the guidelines, and I'll use Josh's statement that they're really a repository of the highest knowledge we have. We all recognize when you open a guideline, you will say there is a level 1 recommendation. And in order for us to say there's a level 1 recommendation to do X, Y, and Z, that means that it's supported by clinical trials, randomized clinical trials, and that we have a high level of evidence to do certain things. And that's sort of the highest level of knowledge. But there are a lot of questions in a day-to-day practice that don't have that level of evidence, and we still have to take care of the patients. And that's why the college and people who sat in the SQC chair before me created something called solution sets. One example is we've had updated heart failure guidelines, but we needed example of how, when you are discharging hospitalized patient from the hospital and patient was hospitalized with heart failure, what do you do? Do you add all 4 drugs at the same time? What are the challenges? Sometimes, how do you go in a practical sense? And that's where expert consensus pathways comes into place. We don't have randomized trial evidence for every single decision making, but it becomes incredibly important on how to do things in daily practice. So that was a long way of answering, hopefully, in part your question, Cathie, of how I got involved. I'm truly grateful and excited about the opportunity of what SQC is continuing to do and collaboration with the guideline committee.
So we've heard about some of the incredible tools that we have, the ACC roundtables, for instance, where we pull patients, insurers, health systems, physicians together. We've heard about the solution sets and the expert consensus documents that are so important to us. So Jae, here's your opportunity. So what piece of advice to the thousands that are listening to us right after the Thanksgiving holiday and right before the Christmas holiday, what words of advice can you give to CVT members to help them implement, just to be knowing full well that they're seeing patients maybe every 20 or 30 minutes, they have full clinics, they're collaborating with their physicians. If you had to identify 2 lessons learned on implementing guideline-directed medical therapy, what would you tell them?
Well, that's a great question, although it's hard to limit it to 2, I think. I would send everyone to the guideline hubs on acc.org. They are a terrific summary, and then you can get, like I said, the entire guideline. So if you want to sit and read all 200 pages, that's there for you. But there are slide decks. There are tools that you can use to, say, for example, you're on the AFib guideline. You can link through to the CHA2DS2-VASc score. So everything you need to care for that patient in front of you is potentially at your fingertips. And again, customize it to what you need. If you are educating other learners, use those slide decks. Pull from I'm looking at the heart failure page right now. There are tremendous opportunities for just short little bites of education. And finally, I think that these are tools that can be used for shared decision making. First of all, if you're on the Heart Failure Hub, for example, and this is true for all of the guideline hubs, you can link through to CardioSmart, which is patient education. I'm sure that all of us have used it, and there are tons of CVT members out there who use it every day, that you can find all the patient-specific education you need through these links. And there are things you can print out. There are PDFs you can download and send to patients or put in their electronic record. There are videos that patients can watch. So I know, for example, I've had trouble in the past. I remember I had a patient years ago who went to atrial fibrillation, and he was a skier. And he didn't necessarily want to go on anticoagulation because he was worried about falling and having a serious injury. And I was able to walk through how we scored him and why I thought he needed anticoagulation. You can do that in real time in front of a patient on an iPad or on your computer in the room with them. You have the entire expertise and gravitas of the ACC behind you as you're communicating your recommendations for this patient. So you're not by yourself in the room with the patient. You have your entire professional home there with you. And I think it's just tremendous. And I will say, I didn't know about this tool. The conversation before this talk was great. Ana Barac mentioned the clinical solutions for everyday practice, and I've never seen those, but I flipped up. I went to the website she put in our chat, and phenomenal opportunity. It's just a different way to get at the same information. So poke around on the website, poke around in the app, see what fits you the best. Bookmark those things and use them in your everyday practice. You know the questions that come up for you, so make sure they're at your fingertips, or the answers are at your fingertips.
Well, and I think what's so important is even for the five of us that are so, or four of us, there's not five here, four of us, that are so embedded in the college, we learn every day different tools that we can find. We learn from each other, which is so important from a networking perspective. And working together is just critical to what we do. And speaking of working together, Josh, we've been doing guidelines for a long time with American Heart Association. So tell me what I know that you're leaving on your white horse. I know you've said a decade with Josh is enough, but we're going to miss you, and I know we're going to find you because we always know where to find you. What are you hoping the next 5 years? What would you love to see as part of your legacy and where we're going, specifically with guidelines, but maybe with some of the expert consensus documents?
That is such, thank you very much for the opportunity just to even participate in this way and give some recommendations. But I want to lean into a couple of things. One, we're going to have to keep up with the technological revolution, and we're going to be doing that, right? There will be ways of getting the documents out more quickly that we're going to lean into. Secondly, I want to make the documents as consistent in both style, form, and creation as possible. The more we can remove surprises, the better everybody can understand where we're moving forward and what to expect. And also that allows us to update them more quickly. We will be updating documents more and more frequently as we figure out each and every step to shorten the time of creation. And when you do that, there's no single recommendation that becomes so important anymore. I have invited over my time on the Joint Committee as much academic writing as possible concerning the guidelines, because we don't think that any opinion is static. We change our committee's memberships, writing committee, joint committee, review committees, because people take a look at the evidence differently and things evolve over time. So I would like everybody to be able to participate, and if we have a standard format, coloring within the lines to update things should be much easier. I also think, and I cannot wait to see this, how we integrate the product that we create that will work with the ACC's methods of implementation to get them the last centimeter, so to speak, from the PDF, which, by the way, I don't think will be a PDF very much longer, to someone's fingertips, is something that I'm incredibly excited about. And then finally, I want people to realize that not only will we have better content management, which is coming online as I speak now, but we're going to have a single repository in a digital form of the entire cardiovascular set of guidelines, which means we're going to have in one place, as much as possible, recommendations for every cardiovascular condition that we are granted the opportunity to try and adjudicate. That means that interactions between different diseases should be made easier to figure out. We should be able to query the entire repository of knowledge in a far more facile manner, and we will not be beholden, so to speak, to separate little groups. We're going to be able to come together as greater pieces of a whole, because cardiovascular medicine, as we all know, is a specific specialty, and we should have all of our specialty information in one place. So we are moving to standardize things, unify things, speed things up, understand how technology can make us better, but not take us out of the loop, and make it easier by working with the ACC to get all of our work to people who are listening to this conversation.
Yeah, and I sort of wish that we had some interchange with our audience so they could ask us some questions. So I'm going to try to channel some of that, because I think we've talked about the incredible rapid acceleration of medical knowledge. and where and how AI is entering into our world. So Ana, as we well know, and Josh is talking about it, we've got to make it simpler. We cannot have 200 pages. Epic won't allow for 200 pages. A clinic visit won't allow for 200 pages. So as we get that actionable knowledge at that point of care, and we look at the integration of our emerging science, and we look at the interdisciplinary approach, which you have done your career with oncology in a beautiful fashion. What recommendation would you give to our audience as it relates to embedding this in their practice? How do we convince people that we need to manage AI, that it really is going to help us from a science and quality perspective? We will never, it's a collaborative AI, I think, as Ana Barac likes to refer to it, that it's really us and that machine learning. Are you doing anything with that in science and quality as it relates to either our solution sets or our clinical guidelines or expert consensus documents? What says you today?
So the answer is yes. And the answer to how to address our needs for better automation, to use artificial intelligence, is to have us create the data and continuing to work with the joint HACC guideline committee. What questions will be designed so that they can answer our specific and granular clinical questions. The goal is to connect those two websites, all the guideline hub with the clinical solutions. They will live in a single space, and most importantly, they need to become the source that AI is going to mind when you ask the next question. So you do not Google, you go to a hub for a specific question, and ultimately, that when we empower our community, we will empower the patient. So that's really where the answer lays. If you need to improve your cardiovascular health, that's the answer for the patient. Well, I think that's the real power, and that's why sometimes the expansion of AI in this specific area, I think it's always looked at skepticism, because AI learns based on what you feed it. So we have to feed with our common knowledge we've developed through focus documents that will be collated and live on the professional society websites. So I think we need the entire village in this, both to inform our needs, to produce the knowledge, and then ultimately to implement the knowledge and improve health.
Well, and I think we talk a lot about it taking a village as we continue to care for our cardiovascular patients. And I think, as Jae has mentioned, even embedding shared decision-making becomes so important, because we cannot possibly have our patients follow guideline-directed medical therapy if they're not aligned with us, if we don't understand their social determinants of health and everything that goes along with them. I think we've talked a little bit about the professional development just of our clinicians as they utilize these guidelines and consensus decision-making documents that we have. So in our last couple of minutes together, maybe Jae, if you want to share with the world of cardiology who is listening to us today, what would be your Christmas present, your holiday present to them as we enter into the holiday season, regardless of your nationality? Hanukkah, all of our members out there, what would be your gift to them this holiday season as it relates to utilizing these documents the best way possible?
Oh, wow. I think that's a great question, Cathie. I think, again, the guideline hub is so rich. Make sure that you utilize it every day in your practice. But I think also, Josh and Ana and Cathie, you all spoke about the importance of getting engaged. When I think about the CVT members, I think their ability to have an impact on the science, sometimes they don't understand what it is. And I heard us all talking about, getting on committees and getting on councils and sections. The one gift I can say is find your people at ACC, whether it's through micro volunteering. There's a tremendous amount of work product that comes out of the work groups, and those aren't competitive. Whereas section and council membership is competitive, and rightly so, because we're asking these folks to make our guidelines, right? But find your folks, get engaged, And Joshua, your story of working your way through every aspect of guideline writing, I thought was perfect. I mean, there's so many opportunities within the college, so get out there and get engaged, find your community.
Josh, imparting words of wisdom for our youngins as well as some of our middle-aged.
So for me, I actually think that one of my goals in my career was to have as much impact as I can. And you can have an impact on a day-to-day basis when you see your patients, and you can make life-changing decisions every single day in the office. You can decide to do some quality improvement work or research, and through each of those, you're not going to have a day-to-day improvement, but if you devote your time over weeks, months, days, years, you will then be able to make changes in the way that people understand problems or people manage problems. I think the other way to have impact in your career is to work through organizations like the ACC. The ACC has many opportunities to participate in cardiovascular medicine on a national level and on a local level. And the ones that I chose to serve are the ones where I try and help people figure out the best ways to take care of their patients through guideline writing, review, creation, and supervision. So I think that this is one pathway out of many. And if I had anything I could tell people in their early career or mid-career phase, one, it's never too late. You can always jump in and participate with 2 feet. 2, you don't have to make the right choice the first time. You just have to show up and do your work and then decide if this is the pathway you want to continue on. And 3, there's always people like me who are at the little bit higher up on the escalator, and they're happy to give you advice so you don't trip and you get to do the stuff you want to do. So I would say, go to the ACC website, see the different opportunities, and if you can't figure it out, there are more than enough people who can actually help serve as a guide and provide you and direct you to different options. But that's what I would say. That is the third stool of the third leg of the stool for how to have an impact in your career. Locally, long-standing questions, national opportunities. And that's what I would say I've been trying to do, and I would be my advice.
Well, and it's such excellent advice, and I happen to be at the Heart House right now, and your advice reminds me of our statue right outside, which is man helping man, woman helping man, woman helping us all, helping each other and reaching behind us to make sure, because we got here through a totem pole. We stand on those shoulders of giants, and guidelines are an amazing example of that. I mean, they started as dissertations, and now we have them at the point of care. We have them in real life, managing real patients. And under Science and Quality's tutelage and incredible expertise, I am so excited to see what the next 5 years bring. I heard a rumor that we may have 5 or 6 guidelines next year, so Josh's legacy will live. He's gotten them moving a little bit quicker. I think with Ana's team that we continue to see the ability to make changes, because science is not static. We've just talked about that the incredible pace of change and making sure our guidelines keep up with that pace of change is so very, very important. But the most critical piece of all of this is to involve our patients, to ensure that we have equitable access no matter what our patient's disease process is, that they have a care team that truly cares about them and understands their culture. This is such an interesting topic to me. Those of you that know me know that science was my bedrock, but I've learned so much from the 3 of you today. And I'd like to make sure that you stay tuned, because we'll be doing some leadership pages around this critical topic, because I think it's so important for our members to understand exactly what these documents are and what we can really do with them. So I'll give each of you a minute to do some parting thoughts, and then we have a wonderful toast for everybody. So parting thoughts, Ana.
Wow, this is a dream come true. Thank you for having me as part of this conversation. Excited to be part of it as a member and also as the SQC chair. Those were the words from Josh, beautifully said. How to get engaged, I will just add to all the members, particularly fellows and junior colleagues, follow your passion. The tools will allow you to be great and efficient. When you want to spend the nights up on something that's not done well, then find what you're really passionate about and then find your community. It's probably living already there at the ACC. And thank you, Cathie, for having me as part of this call.
Jae.
I loved what Josh said. Not to repeat, but to have as much impact as you can. And I think that's always been something that I've thought about, but I've never worded it. You should be writing the guidelines, Josh, because you're very good at distilling that information. But yeah, think about the way the college can support you in having that individual impact on individual patients, but also think about how the college gives us a platform for advocacy, for science, for connecting with other folks who are doing this work to do things like create guidelines. Yeah, expand your impact.
Josh, any more parting words? You've left us with so many pearls of wisdom.
Just one more. First, two more. One, it's been a huge opportunity and privilege to be able to work with the group of people with whom I work. They put in so much time and effort that I'm just lucky enough to be able to sit here with you, but without the group of people over time, none of this would get done. Secondly, the last thing I'll say is that this kind of work and all the other things we've mentioned is an opportunity to create the future and not let the future hit you. So if you want to be able to be the ones to guide where we're going to go, jump in with 2 feet. Because no matter how much people edit what you do, 80% of every effort is yours when you do it first.
So with that, as is a tradition with our podcast, I ask each of you to raise your glass. I didn't put color in here, so you can't really see our 75th anniversary. Oh, Jay's got color in it. So to our totem poles, as Josh said, to those that support us every day and assist us in this work every day, to those of you that take care of our patients every single day, 24/7, we cannot begin to thank you for everything you do in the field. We are simply here to try to help your jobs be a little bit easier. And so with the holidays upon us, may the wind always be at your back and the sun always in your face. And thank you so very much for joining us today. Here's to everybody and to a great 2025 in fighting that global burden of heart disease. Thanks, everyone.
Thank you, Cathie.